Chapter 2, Basic Structure and Function of Human Joints. In this chapter, we're going to talk about a number of things related to the basic structure and function of joints. First thing we're going to discuss is basically arthrology, or the naming of the different types of joints in the body. And we're going to start out with the syndesmosis. Now, the syndesmosis joint is a joint with slight or no movement. And in this slide, we see a couple of examples. So the picture on the left is of the manubrosternal joint. And although there's slight movement in children, as we get older and naturally get stiffer, that basically turns into a rigid, unmoving structure, much like the cranial bones on the right, the sutures of the cranial bones. So we have different examples, including cartilaginous structures such as the pubic symphysis. And together, these joints form a strong bond or bind between two bones, transfer forces. So that is the purpose. There's really no movement associated with them, just for the transfer of forces. As opposed to those types of joints, we have diarthroses, which are essentially synovial joints, where we think of as classic joints with movement that allow us to interact with our environment. And these types of joints always possess 7 elements. Firstly, it must have articular cartilage. So articular cartilage is, of course, the cartilage at the very ends of our bony structures. And what type of collagen is articular collagen or cartilage? Is it type 1 or is it type 2? It is type 2, correct. It also must have an articular capsule surrounding the two bones. This structure is relatively tough and gives a semblance of structure and stability to the joint, along with several other structures in the joint area. It also must have a synovial membrane. Synovial membrane is essentially the very most inner layer portion of the joint capsule. And it interacts, of course, with synovial fluid, which helps reduce friction, provide nourishment to the joint itself. Now, the synovial fluid and the articular cartilage make the coefficient of friction within the joint very, very slippery. And where the coefficient of wet ice on wet ice is 0.1, the coefficient of articular joints is much, much lower than that. It's much more slippery than that. And I have actually felt it within the emergency room when I was watching a knee procedure. Very, very slippery stuff. Diarthrosis joints also have ligaments that fortify the capsule, but in reality, many of these ligaments are interwoven into the joint capsule itself. A great example of that is the superior, middle, and inferior portion of the glenohumeral ligament anteriorly in the shoulder. So they're basically thickened portions of that joint capsule. Other ligaments are much more independent, if you will. They are much more distinct, such as the fibular collateral ligament at the knee. It's very, very distinct. Diarthrosis joints also possess sensory nerves, both for pain or nociception and for joint sensing function, like mechanoreceptors that tell our body what's happening in the joint so we can stay on our feet and function appropriately. And finally, diarthrosis joints have blood vessels to feed the capsule, and that capsular vascularization goes down to the very edge of the synovial membrane of the joint. So those are the 7 elements. Now, some joints possess additional elements, and these include interarticular disc, for example, the meniscus, in the knee, and a disc in our temporomandibular joint. We also have peripheral labrums in our shoulder and our hip that serve to deepen the socket and provide additional measure of stability. Some joints have fat pads, which are essentially fillers to reduce the volume needed in the joint for the synovial fluid. And large joint capsules, such as the knee and the elbow, are where these are most predominantly found. Additionally, some joints have bursa. So the knee has many bursa around it, including the prepatellar bursa, suprapatellar, and infrapatellar bursas. And there's a very important bursa in the anterior elbow, which helps physicians detect whether there's a fracture in the elbow that doesn't show up very well typically on x-ray. You'll see a sail sign, which I'm sure you'll see in radiology. So bursa essentially protects one structure from rubbing on another, and it's usually a tendon from rubbing on a bone to protect that structure. Finally, some diarthroses joints possess a synovial plica, which is an overlapping set of tissue that is comprised of the very innermost layer of the joint capsule. Basically assists with increasing the synovial surface area and allows full joint motion without excessive tension on the synovial lining itself. So it kind of protects that synovial lining, gives it some measure of structure. Okay, so the next thing we're going to talk about is mechanical analogies of the different types of synovial joints. In this picture, you can see 1, 2, 3, 4, 5, 6, and I've put a 7th one off to the left. I'll explain that in a little bit. So basically we have our ball and socket joints, which are consistent with our hip and shoulder. Ellipsoid joints and ellipsoid, we'll show a picture of that a little bit. We have hinge joints, such as the elbow. We have our saddle joints, where we have a biconvex, biconcave relationship, where in one plane it'll be convex on concave, and on another plane it'll be concave on convex motion, such as the first carpal metacarpal joint. We have gliding joints, and finally we have pivot joints, where there's axial rotation, such as at the radial head on the capitellum. Now, we also have condylar type of joint. I'll show you just right here. And that is consistent with like the knee joint. And it's very much like our ellipsoid joint, where there's a convex and concave member. But this time, instead, and while they're very interrelated, the ellipsoid joint and the condylar joint, this time we'll show a little later that condylar joints have bony prominences, and in fact condylar means knuckle. So that's what distinguishes it from that, as opposed to the ellipsoid joint as we see at the wrist. Next, we're going to talk about the different types of joints in a little more detail, and their mechanical analogies. For example, our first one here is the hinge joint. And with a hinge joint, we have flexion extension of the joint only. So this is a single axis of rotation, where angular motion occurs at the right angle to the axis of rotation. So elbow flexion at the humeral ulnar joint is the classic example. You can see it here. It's like a hinge of a door. The phalangeal joints are also considered to be hinge joints in this text, although some texts may call them something else. But in this text, and for the purpose of our discussion, we'll consider them hinge joints. The elbow joint is the closest to a pure axial rotation that occurs in the body. We'll see what that means more a little bit later, but it's not quite, because the joint is not exactly like a hinge, but it's close. Next, we have a pivot joint. So in a pivot joint, we have a spinning of motion around a single rotational axis. So I already gave you the example in the slide before on the humeroradial joint or the capitellar joint, where in pro and supination of the forearm, the head of the radius articulates on the capitellum of the humerus in a rotatory fashion, like a doorknob. So you see this in the picture on the right, where the head of the radius. You also see it here on this picture that portrays the atlas of C1 here, with the axis below C2 and the dens coming up. So the dens is held by the transverse ligament right here, and there's a tremendous amount of rotatory mobility of C1 on C2 when we perform rotation in the horizontal plane for the cervical spine. So those are examples of pivot joints. Next, we have an ellipsoid joint, and this is a biplanar joint where we have convexity and concavity that occur in both directions. So this is a biplanar joint, which means there's two motions available. And with the ellipsoid joint, we have a shallow, flat surface with elongated surface also. And that elongation, as opposed to, for example, the ball and socket type of joint, that elongation restricts and does not enable rotatory forces to occur. So we have flexion extension. In the case of the wrist here, the classic example, we have flexion extension, and we have radial and ulnar deviation. Again, motions occur in two planes at right angles from each other. So the radiocarpal joint is a great example of that. All right. So because in the open chain we have the convex surface moving on a concave surface, when we go into flexion of the wrist, we get extension or dorsal posterior gliding of the scaphoid on the radius. And when we go into radial deviation, we get a slide or a glide in the ulnar deviated position. So here's our ellipsoid here. This is what an ellipsoid looks like. It's an oval shape. It's got height and length and depth to it. So that's our ellipsoid joint. Next, we have our condyloid joint. This is a biplanar motion also. Now, it's biplanar in the knee because it also involves rotation, which we talked about, I think, in the last lecture, but it can also involve, like at the carpometacarpal joints in the hand or the tarsal metatarsal joints in the foot, we can have abduction, adduction as an additional component to that. So again, just like the ellipsoid joint, the condyloid joint is a biplanar joint with motion in two directions. So we have the knee, we get flexion extension with a little bit of what? Internal or external rotation as we go into terminal knee extension. Do you recall? It's lateral rotation. And when we go into flexion, we get essentially a medial rotation of the tibia on the femur. In the metacarpal phalangeal joints in the hand, we get flexion extension and some abduction adduction using our lumbricals. So again, the condyloid joint and the ellipsoid joint are essentially the same, only with the condyloid joint, it by definition is a knuckle, where there's an enlargement at one end. So think knuckle here. Where at the wrist, if you look at your wrist, yeah, we have the ulnar styloid, the radial styloid, the ulnar head near the wrist, but really the joint itself does not have a knuckle. So that is an ellipsoid joint. The knee, if you look at it from the top, also looks like an ellipsoid, but because of the enlargement at one end, it's a knuckle joint or a condyloid. Next, we have our traditional ball and socket triplanar joint. So motion occurs in three planes. The sagittal, the frontal, and the horizontal plane in the examples of the shoulder and the hip. So that symmetry of the ball on the socket allows the surfaces to spin on each other, as opposed to our ellipsoid and condylar joint, where we don't really have that third plane of motion because of the asymmetry of the joint surfaces. So with our ball and socket, we have, again, 3 planes of motion, and those joints allow the greatest amount of angular freedom in the body. Next, we have our plane joint, which are a plane joint is the junction of 2 flat or slightly curved surfaces where motion is created not by direct muscle attachment pulling on that bone, but by ligament or muscle tension as it crosses the bone. So there's really no, for example, muscle that attaches on the cuboid here, right? Here's our cuboid, here's our navicular bone. Here is the planar joint right here between those two. And you remember what ligament this is that causes the arch? It's the spring ligament, right? We have our posterior tibialis. It courses medially in the ankle and goes to the bottom of the foot. But this joint is a planar joint, so when we load that spring ligament, keeps it from falling down, and we get a resultant slide or glide of this joint surface. But again, it's in response to tension of the ligament or muscle as opposed to direct action of a muscle on the joint. So our intercarpal and intratarsal joints are great examples of these. Again, prime movers do not act upon them. They occur as the forces around them dictate. Next, we have our saddle joint, which is our biconcave, biconvex surface. So here in the picture on the right, you can see that when we go in this direction, as shown with the green bone, we have a concave surface moving on a convex member. But when we go the opposite direction, we have a convex on concave. So we'll get slide and glide in one direction, or the same direction in one way, and slide, roll and glide in the opposite direction the other way. We can feel that also here's a picture of our sternoclavicular joint. So with our sternoclavicular joint, if you could feel that with your finger right now, when you elevate the shoulder, okay, when you elevate the shoulder up, scapula up, with your ear towards, or should say your shoulder towards your ear, you'll feel that the clavicle drops down in the sternal notch, okay? It drops. However, if you protract the shoulder, you can feel that on yourself. When you protract the shoulder, that movement, that roll goes forward, and slide and glide also go forward. So that is an example of a concave on convex in that plane when you retract and protract the shoulder. But when you elevate in the frontal plane, we get a concave on convex surface. So it's just like the shoulder. So when you elevate your shoulder towards your ear using your scapular elevators, we get a drop of the clavicular and near the sternum down in the clavicular notch. So those move in opposite directions. Another example we talked about before is the carpometacarpal joint of the thumb. Those are the 2 primary saddle joints in our bodies. All right, so when we're determining our axis of rotation, we have to understand that the path of that motion changes as joint rotation occurs. So in a pure hinge, for example, a door, the axis of rotation stays in exactly the same place. And like we talked about before, in the elbow, because it's a hinge joint, it is pretty close, so that axis of rotation does not change much for that joint, but for our other joints in the body, it changes to a fair degree. So the point is that joint axes are not pure. So they change with every degree of motion in that particular joint. So we have this term called the instantaneous center of rotation. And what that means is at that particular degree, for example, at the talocrural joint, if we bend our ankle into dorsiflexion from, let's say, -10 from 0 to a 0 or neutral position, the axis of rotation within the talocrural joint changes at each degree. So that means the instantaneous, when you hear instantaneous axis of rotation, that means that it is particular to that degree of motion. Now, obviously, we can't measure that each time. It's much too complicated, but nevertheless, you should understand that that is the case. Okay, so that arc of motion you see here in the knee joint, here's the femur, here's the tibia, as the knee flexes, so this is extension because here's our patella, the instantaneous axis of rotation goes from here and rolls back up into the femur a little bit in a curved glide. So as we flex the knees, the tibia rolls backwards. It also slides backwards, and that changes the instantaneous axis of rotation. And that arc of change is called the evolute, E-V-O-L-U-T-E, the evolute. All right, that is measurable. So when we perform goniometry, we're really not concerned about trying to figure out exactly where the axis of rotation is, but we should understand that that axis of rotation lies within the convex member of the joint. So when we move the shoulder into shoulder flexion, the axis of rotation is not in the scapula, it's in the humeral head. When we look at the knee, the axis of rotation is in the femur, not the tibia, because those are the convex members of those joints. We can precisely determine the axis of rotation with x-rays. You see here, I'm going to blow this up a little bit. See here, they have marked on the tibia point A and B, and as the joint flexes, so it goes from this position in a fully extended position, we flex the knee to 90 degrees, and the same points we draw perfectly perpendicular lines through the femur this way and through the femur this way, and the intersection of those lines is where the instantaneous axis or center of rotation lies. So as we continue to flex the knee further, okay, as we continue to flex the knee further, this axis of rotation moves in this direction. So you can see here, it goes from this position to this position here. So as it flexes, the axis of rotation changes. And that's measurable on radiographs. We don't do it in real life. Okay, histology of joint tissue. Well, fortunately, we've talked about this before. We're going to talk about collagen and elastin. Collagen, we have two types of collagen, type 1 and type 2. Type 1 collagen is a thicker fiber, and I want you to remember that that stretches a little bit under tension. So it's strong and stiff and gives good resistance to tensile loading, and it's the primary protein in ligaments and the capsular structure itself. So think type 1 for resisting tensile load, pulling apart. Where type 2 collagen is a thinner collagen, provides a framework for the shape of tissue. In this instance, we're talking about tissue like hyaline cartilage, where it provides a good resistance to axial loading because type 2 collagen is essentially building blocks for that hyaline structure. And finally, we have elastin, which is exactly what it sounds like, elastic. They also resist tensile stretch, but tend to give more than a type 1 collagen. And the amount of elastin will vary depending on the tissue itself and even between individuals depending on their genetic makeup. All right, we talked about ground substance a little bit last semester. It's basically the glue that holds these things together. So the elastin fibers, collagen fibers, and so forth lie in this ground substance. And it's essentially embedded in this watery matrix, which is basically made up of glycosaminoglycans, or GAGs, water and solutes. So GAGs give a physical resilience to the ground substance. And the reason they do so is because they're highly negative charged and hydrophilic. Therefore, the GAGs hold about 50 times their weight in water, which causes swelling, quote unquote, to the tissue, not the bad kind of swelling, but a kind of swelling that you experience, for example, in a water balloon. So it resists compression very nicely. So that swelling is actually a positive thing. So there are three types of periarticular connective tissue: dense connective tissue, articular cartilage, and fibrocartilage. You can see in the picture here the aqua shades of blue. We have our dense connective tissue, which is really the fibrous capsule. We have articular cartilage, which of course is at the end of the long bones that make up our diarthrotic joints. And then we have our fibrocartilage, which in this instance in the knee are the meniscus. Or it could be the disc material in the lumbar or cervical thoracic spine, or labral material in the shoulder and the hip complex. Histology. The makeup of the tissue, of course, is going to be different, whether it's dense connective, articular, or fibrocartilage. And in our second column here, we have collagen fiber type. So parallel type 1 fibers make up our dense connective tissue, and that kind of makes sense because the capsule, the joint capsule, while it should be strong, should also have some stretch to it. So this has some elastin to it, so that the normal physiologic forces that we experience is a little bit of give in the joint. That's a must. Articular cartilage is made up of type 2 fibers. We know that those are the building blocks and are very resistant to load bearing. And then fibrocartilage, or meniscus, or labral tissue, is type 1 again, that are multi-directional fibers as opposed to these parallel fibers running all in one direction. Fibrocartilage runs in many different directions and increases the strength, the load-bearing capacity of that tissue. The proteoglycan content of dense connective tissue is low to moderate. Okay? Remember, these proteoglycans are hydrophilic and help with stiffness of tissue. We don't want this as stiff as we do, for example, articular cartilage. The proteoglycan content is high here, and the fibrocartilage is not as resilient to load as the articular cartilage, but still relatively moderate degree of proteoglycan content. I want you guys to know Table 2.2. This is an important table to know and understand as we go forward through the course. Function and importance. Dense connective tissue's primary function is to resist tensile load, right? So our joint capsule, our ligaments, and we're not talking about muscle yet, but the tendinous tissue is dense connective tissue. Articular cartilage, we know, resists compression, shear, and friction in our joints. And our fibrocartilage distributes load and guides osteokinematics, whether that's the disc, the labrum, or the meniscus. The clinical significance of them, clearly, if we have a joint capsule is torn, we have joint instability. If we have a partial tear, it can also lead to instability, relative instability in the joint, and eventual osteoarthritis. This is a theme we've talked about several times, where when a joint becomes too mobile or relatively hypermobile, it leads to sloppiness in the joint, which eventually leads to osteoarthritis in the joint. Articular cartilage. In early osteoarthritis, we have a loss of the proteoglycan complexes and a loss, therefore, of the load-bearing capacity of that tissue. And of course, fibrocartilage, such as labral or meniscus tears, also lead to subtle instabilities and joint dysfunction down the road. That's why many times people will opt for meniscus repair in the knee, because if you cut it out, what happens is that it destabilizes the joint and tends to lead to earlier osteoarthritis. Additional facts. Articular cartilage and fibrocartilage are relatively aneural. What does aneural mean? It means that there's no nerve supply. Now that's relative, largely. So here, for our disc, I'm just going to show you. Here's the disc. Of course, this is the nucleus pulposus in the middle. We have the annular layers on the outside, many of those. This right here is the sinuvertebral nerve, right here. This is sinuvertebral nerve, okay? And you can see that it penetrates into the very outer walls of the annulus a little bit. And that helps us because the sinuvertebral nerve is monosegmentally innervated. In other words, every level, let's take L4-5, every level is innervated by one nerve root for the sinuvertebral nerve. So when we get a small distribution or a small complaint area of pain in the lower back that is pinpoint like a thumbprint, we're pretty sure it's going to be the sinuvertebral nerve because it is monosegmentally innervated. Once the insult gets out further away from the disc and starts to push on the outer layers of the disc material, then we have tissues that are polysegmentally innervated from 2, 3, and 4 segments, which means that the pain distribution is going to be much larger. So the lumbar spine is really cool as far as the neuroanatomy of it, help us figure out what's going on clinically. Articular cartilage and fibrocartilage are partially vascular. Okay, it's generally the outer layer. Okay, so here's our meniscus looking from the top on the tibia. Medial is larger, all right? Lateral is smaller. We also know the fibular head is over here. That red zone is at least partially vascular. So if we get a tear to that on the outside, they usually repair that, and they're doing it in older and older people because they realize the detrimental effects of cutting it out. But if tear is in the inner part right here, that white section, that is avascular, which means it is not going to heal well. So it's very difficult, if not impossible, to repair that and have a good outcome. So hopefully your meniscus tears would be on the outside part. All right, joints, of course, have sensory innervation. There are 4 basic types it talks about in text. It's not a neuroanatomy class, we're just covering some of the basic things that the text is discussing. The first 3 types they talk about are mechanoreceptors, and the 4th type, type 4, is a nociceptor. Type 1 is a Ruffini receptor, type 2, Pacini, type 3, a Golgi type or like receptor. And that should sound familiar from within our tendon structure too. And type 4 is our free nerve endings. So if I'm going to blow this up a little bit, our Ruffini receptors are on the outside of the joint capsule. So they're the very outer layer, okay, where our type 2 Pacini fibers are the inner layer, not the innermost, because that's the synovial membrane, right? But the inner layer of the joint capsule are type 2. There are Golgi type fibers within the joint structure is in the ligament itself. That gives us information about what's going on with the joint towards the end range, just like the tendon Golgi, tendon organ. And then finally, type 4 are free nerve endings. So that's these little guys right here, and those, of course, give our body information on nociception of pain. So when we stretch that capsule or we injure or twist our knee, it gives us information that we've created some damage and therefore causes us to avoid activity that might make things worse. All right, highlights of joint pathology. I would like you to read, please, pages 42 to 44 and at least get a gist or an understanding of what it's talking about. Come to the lecture with questions if you do. Here's just a few basic highlights. So we have discussed these before, looking at acute trauma, where after acute trauma, we have a predictable healing process. We have inflammation, we have laying down of new tissue, and then we have the remodeling of that tissue. Overuse is a little bit different, right? So we don't necessarily have a blowout ligament tear or muscle tear, but overuse can result in ischemia or mild inflammation, and those are going to be treated a little bit different. They're not going to go through the exact same process. Longer moment arms are subject to ligament damage, and that makes sense, right? Because, for example, the knee, the shoulder, those joints that have long bones are more likely to sustain ligamentous instability and ligamentous tears than smaller ones. We're increasingly doing meniscus repair over the meniscectomies because, again, we don't want to destabilize that joint. And finally, there are 3 basic types of osteoarthritis I want you to remember. One is idiopathic. What this essentially is referring to is folks that just have normal wear and tear over a lifespan of activity. Now, sometimes people end up with only left knee osteoarthritis, idiopathically. Why do you think that is? The reason is probably that they have other biomechanical deficits in the lower extremity that is causing increased load to that particular tibiofemoral joint. So it's not like it just kind of comes out of the blue necessarily, but there are usually reasons for people having joint dysfunction. If the mechanics are really good and there's no injury, usually we don't end up with idiopathic arthritis. Generalized osteoarthritis is our grandma and grandpas that have kind of aches and pains all over, that have swelling in their knuckles, that have arthritis in their hands and their feet and their knees and kind of everywhere. And then our post-traumatic arthritis are those folks, generally younger, that sustain an injury. I'm going to give you a good example. Let's say somebody has a car accident and they develop a tibial plateau fracture. So with tibial plateau fractures, that injury is pretty bad. It causes a lot of swelling locally and even into the joint. And some people, for some reason, develop this cascading, rapidly developing arthritis in the joint after an injury like that. Other people do not. They get normal healing of the bone and they have some stiffness in the knee and they work it out and everything's okay. But many people develop post-traumatic osteoarthritis, and it's usually within a few months to up to a year or so after the injury, and it's a rapidly developing arthritis as opposed to our idiopathic, slow, normal, age-related osteoarthritis. All right. Although we're done with the chapter, those of you that would like to go over a quick review of the upper extremity joints with regard to the type of the joint they are, how many degrees of freedom they have, and the plane in which those movements take place, can watch the rest of this video that consists only of this slide. So if you feel like you have a good grasp of things, you don't have to watch this. But here we go. So we're going to start with the most proximal joint, which is our sternoclavicular joint. We talked already about how this one is a saddle joint, right? Saddle. So how many degrees of freedom does that have? Okay, and when we do protraction, retraction, is it convex on concave or concave on convex? And when we do shoulder girdle elevation, is that concave on convex or convex on concave? Well, a saddle joint has 2 degrees of freedom. In this case, elevation and depression and pro and retraction. In elevation and depression, it's a convex on concave surface. Therefore, the roll occurs in the direction of the movement and the slide or glide goes opposite. Not so with our protraction retraction. When we protract the shoulder girdle, we get a roll anteriorly and we get a slide glide anteriorly. And the same is true going backwards, goes in the same direction. Posterior roll, posterior slide glide. All right, so that's a saddle joint. Next is the acromioclavicular joint. What does that look like to you? Does it look like a ball and socket? Does it look like a saddle? Does it look like an ellipsoid? What is it? Well, in fact, it's a planar joint, right? So planar joints, really you can't describe in degrees of freedom because remember, they respond to what's going on with the muscles and the ligamentous tension around them. So the acromioclavicular joint is a planar joint. How about the shoulder joint, the glenohumeral joint? It is a ball and socket. How many degrees of freedom does it have? 3. And what motion do those occur? Okay, flexion occurs in the sagittal plane. Abduction, adduction occur in the frontal plane, and internal rotation, external rotation occur in the horizontal plane. So it's a triplanar joint. All right, moving down to the elbow. Let's talk about the humeral ulnar joint first, the true elbow joint. What kind of joint is it? It's a hinge joint. How many degrees of freedom does it have? And what plane does that happen in? Okay, so it's a hinge joint. It has 1 degree of freedom, and the motion occurs in the sagittal plane, flexion, extension. All right, now let's talk about the humeral radial joint out here. The humeral radial joint is a what kind of joint? It's a pivot joint because it's primarily responsible for pronation and supination of the forearm in which plane? The horizontal plane. Rotation occurs in the horizontal plane. Now, you might ask why it's not a modified ball and socket joint, because after all, when you flex and extend the elbow, it goes along with and probably articulates somewhat on the capitellum. That's true, but the primary, again, the true elbow joint is on the ulnar side. So this humeral radial joint in our text refers to as a pivot joint. You might find information that's different in other texts, but for our purposes, pivot. All right, 1 degree of rotation. Then we have our proximal radial ulnar joint here. What type of joint is that, do you think? What's happening at it? Well, rotation, right? Pronation, supination. How many degrees of freedom? 1. And what degree, what axis of rotation does that occur in? It occurs in the horizontal plane, right? So it is also a pivot joint, okay? It occurs around 1 axis of rotation. Let's move distally. Talk about the distal radial ulnar joint. What happens here? Right here. Also rotation. So guess what kind of joint it is? It's a pivot joint. How many axes of rotation does it have? 1. In what plane does it occur? It occurs in the horizontal plane. right? All right, moving on. Let's talk about the radiocarpal joint right here. That involves almost completely the scaphoid and the lunate right here. Scapholunate right there. Scaphoid is radial, lunate is central, but more ulnar compared to the scaphoid. So what is this joint here? First of all, how many degrees of freedom does it have? It has 2. In which directions? Flexion, extension, and ulnar and radial deviation. And what planes do those occur? Flexion, extension occurs in the sagittal plane. Ulnar and radial deviation occur in the frontal plane, right? Okay, good. Now we're not going to try. We're going to describe the ulnocarpal joint because that has an articular disc in it. We'll talk about when we get to the wrist later in this course. There's really no true joint on that side. It's kind of filler material. So how about these intercarpal joints? What kind of joint are those? Those are planar joints, okay? They respond how? Through muscle and ligamentous tension. Can we describe their degrees of freedom? Not really. Only nominal motion occurs between them and can occur in multiple directions. So it doesn't occur in sagittal, frontal, or horizontal plane. They occur as the ligamentous and muscle support system dictate, right? All right, so if this is an ellipsoid joint here between the radius and the scaphoid and lunate, ellipsoid occurring in 2 planes. What is this one over here? Well, it's also an ellipsoid. However, functionally, the second ray, that's the metacarpal, and the third ray, metacarpal, are essentially not mobile. They're rigid. Our 4th and 5th rays have a little bit of mobility. So it is an ellipsoid joint here, 2 through 5, ellipsoid, but with limited motion. And those are occurring mostly between 4 and 5. All right, good. How about our first carpometacarpal joint right here? What kind of joint is that? It's a saddle joint. How many degrees of freedom does it have? It has 2. And what planes do those occur in? Well, they occur with CMC flexion occurs in the frontal plane. Extension occurs in the frontal plane. Abduction occurs in the sagittal plane along with adduction, right? So which direction does that happen? Feel your first carpometacarpal joint, right? When you go into flexion, which taking the thumb across towards the 5th digit, what happens? See if you can feel that, all right? When we go across, what we get is we get ulnar directed, or ulnarly directed roll, and we get an ulnarly directed slide. Same the opposite direction. If we go into extension, we get a radial directed roll and a radially directed slide. Now, put your thumb right on the front of that CMC joint on the anterior surface on the radial side and take your thumb into abduction. That comes towards you in the anatomic position. If you abduct the thumb, you'll feel that joint run away from you. So that is a convex on concave motion in abduction, adduction. But in flexion extension, it's concave on convex. Did you get that? Think about that, work through it a little bit. All right, so how about our metacarpal phalangeal joints here and our phalangeal joints? What are those? Well, let's take our metacarpal phalangeal joints first. All right. What kind of joints are those? Those are ellipsoid joints, right? How many degrees of freedom do they have? They have 2. What are those motions? Flexion, extension, and abduction, adduction. Occurring in which plane? Flexion, extension, sagittal plane, and adduction, abduction in the frontal plane by planar joint, 2 motions. Then we have our interphalangeal and distal interphalangeal joints. Which type are those according to the book? Those are hinge joints, okay? 1 degree of freedom, flexion, extension, that's all. All right, and that occurs in which plane? That occurs in the sagittal plane. Okay, good guys. If you don't know those, go through this slide several times. Grab your anatomy book, go through it, practice it yourself, look at what you're doing, and make sure you understand them all. Because this is the type of thing, as we go through our kinesiology book, you're going to have to know. You must know the planes, you must know the directions, you must know the joints, what type of joint they do, degrees of freedom, and so forth. So, happy studying, and we'll see you next time.